Hello, it's me, Vinay from the ConquerCovid team. I'm here with CEO of Global Whole Health Partners, Charles Strongo.
Hi,
And
Vinay. How are you?
great. How are you today?
Very good, thank you.
And I'm very excited to talk to you today. You have a wealth of experience in the rapid diagnostic testing market, and I think there's a lot of cause and concern about test reliability today with manufacturers, and hoping we can dive into some of these topics that are really on people's minds when they're considering moving forward with COVID rapid testing and COVID testing in general.
Excellent. Looking forward.
So, for everyone out there, can you just tell us a little bit about your experience and what has brought you to this point in getting into the COVID-19 rapid testing?
Sure. The COVID testing really wasn't brought into it. It kind of came into us as a world. But I've been in the diagnostic industry since the late 1995. So I've been doing it for 25 plus years. And we were around when the first over-the-counter pregnancy test was done, the ovulation test, the first drug testing, the first strep A testing. And from then on, it's grown to hundreds of different types of tests. So we've learned how to make tests quickly. We've learned how to develop tests quickly. Sometimes we develop tests that no one, even when we think that there's a need for it, we will develop a test. We developed as recent as a rapid Ebola test that we have now. It's not approved in the United States for sale, but it has been approved through what they call a certificate of exportability, where we can export the Ebola test or a Zika test or dengue fever, which is a dastardly disease, even worse than COVID in many countries in the Pacific Rim, where there are a lot of mosquitoes, where hundreds of thousands of people die. And so we developed a antigen and antibody test for dengue fever. So when COVID came up, it wasn't something new to us. A lot of companies, a lot of people went, oh, wow, let's get into the diagnostic industry now. For us, when the COVID showed up, we went, okay, just another disease, just another virus. We supply strep A, influenza, and a variety of different tests, over 100 of them. And because of that, when COVID came up, it was like, oh, okay, another test. Can we develop it? How fast can we develop it? How accurately can we develop it? And our focus has always been not in how quick we can make a test, but our consciousness has been in how accurate the test is. Because to us, when you're dealing with a test that can have fatalities, people die of the flu, tens of thousands of people die of the flu every year, and it is a very serious virus, and we make a very accurate test. Strep A, less serious. But you still want to make it as accurate as possible. So when COVID first came out, we realized that there's a very variance of the symptoms of COVID, from very mild to extremely severe, where young and old can die from it, weak and strong can die from it, and where we needed to be able to come up with a test that was extremely accurate. Does that make you the first one out the door? Not necessarily, but it makes you a very good test.
Yeah.
So when it came to us, we began to develop, and then we ran across, since we've been in the industry for so long, we've developed tremendous relationships all around the world with other manufacturers, because a lot of them we've worked with, they've been in business for 20 years or 22, 23 years. Very few have been in business as long as us. And so we know a lot of people when they first started 20 years ago, and due to relationships, we're able to assist them. So sometimes they'll say, you know what, we're at this point with our test. We need to refine it. Can you help us? And so my chief science officer, his name is, we call him Dr. Sue, and that's not fair to him. His name is Dr. Sinjut Tree, is his proper name. And so Dr. Tree has tremendous contacts. And so we assist and share information back and forth because we're in the business to save lives. We're in the business to protect people. And we've been doing that for 25 years. We've developed tests like cholera, which we, you don't hear about it very much, or our HIV 1 and 2, which also does the O strand or the third strand of HIV. Again, not heard of, but we created things that can save lives. That's our focus. So being in the industry so long, you begin to partner with other groups and to come up with something better. We've done that with other manufacturers. We've partnered with them.
Right. And yeah, to be clear, you've partnered with a few COVID testing manufacturers to
Yes.
produce rapid tests.
Exactly.
Made in San Diego.
Yes. We have partnered with a couple other manufacturers. We won't make mention to them because I have not gotten their permission to say their name. But their name is on our website, and where it is be considered public knowledge, but I have not gotten their permission to say it on something like this. But we've gotten their permission, not only their permission, but we've partnered with them. We've worked with them. We actually make some of their tests in our own facility in San Diego. So that way, we're not just a distributor, we actually manufacture. And we have a facility in San Diego. We have a facility in Escondido, California, which we've set up in such a way where it's GMP approved facilities, manufacturing. So it's a little different, but we do that because we want to guarantee the people who do work with us that the products that they have are all following the proper FDA guidelines and regulations, so they know they're getting something quality out. For example, we're running another set for our new test, which is our antigen test. We have an antibody test with the IgG and the IgM. Now we're doing the antigen. And we ran one set of studies locally. We'll do another set, and we're doing another set right now in Florida. And then we'll do another set probably in Texas. So we'll run 3 different locations, and we'll combine those test results together. And unlike picking the very best one and just running with that, we'll literally combine the 3 tests together and say, this is the test combination. So that way we get a true and accurate test. We can actually know what our our antigen test is. And
if you
right
could
now
explain that a little more, are you testing for just one antigen, or are you testing multiple antigens? Or
that's a good question. Everyone so far that we have seen, if you look up on the FDA websites for the approvals, the tests have what they call an antigen N antigen. And our test that we're doing is N plus S. There are 2 different types. N is a more broad spectrum of the virus. It's a wonderful test. This has a little bit broader spectrum. The S protein, basically the S of the antigen, is very narrow. It's very specific. And by being more specific, it's more for the COVID-19 SARS-2. So it's very specific. So when you combine it, you end up with a very, very good test that is specific and broad at the same time. So that way we're able to not have the false positives or incorrect negatives. It's a better test. That's our opinion. But it's also scientific. But So we're running those tests now. We call N+S antigen tests, and we're running nasal swabs, and we are running presently saliva. So,
yeah, I mean, I think that's critically important.
It is. You have to do an S1 or S to be able to run saliva. It has to be very specific. It has to be extremely sensitive. Otherwise, you're not going to be able to pick up the antigen or the virus inside someone's mouth. And so, many tests run by nanograms per milliliter. This type of test, virus tests, don't. And basically by how many viruses there are per milliliter. But we can calculate, there's a formula on how many there are per nanogram of whatever we're looking for, so we can pick up the sensitivity. And so we feel that the last batch that we've done and that we can reproduce, because when you're doing rapid testing to come up with good quality, you want to have the ability to have what they call reproducibility. Not just, oh, I made one good batch. Lot number XYZ is the best that there is, and I made 5,000. Now XYZ-1, so-so. You can't do that. You have to be able to create a formula that you can reproduce. So that way XYZ1 or XYZ through XYZ1 through 999, the sensitivity and the accuracy overall, actually the test is the same. Or very close, within a tenth of a point, because there are going to be different lots, there's going to be different antigens, antibodies that you're working with, so you're going to have a slight variance, but a tenth of a percentage point you don't mind. What you do mind is 2 or 3 or 4 or 5 percentage points off, or as much as 4 or 5 or 10. I've seen that. So, and that is due to the quality of the antigen that you're buying to make an antibody test, or an antibodies that you're buying to create an antigen test. And so in that process, your ability to have reproducibility in your formula is really important. It's called pairing. You have a good pairing match. So we have been able to come up with a very sensitive antigen test that we feel will be effective with saliva. Do we know that for sure? No. Have we done the studies ourselves, several hundred of them? Yes. Have they come out well? Yes. Have they been verified by another lab? Yes. But is it significant enough for us to make that statement that we know we can have a saliva test? No, not at all. So even though we've done one small lab study, we are now doing several hundred tests on high complexity, clear wave certified FDA labs for them to give us the conclusion. So our opinion that has nothing to do with it. It's purely blind studied out. So when we do get the results, we know it's true. And so we're doing that right now. And we're hopeful that it comes out good. If it does, we will add and we will change our FDA filing, which we've already filed for the antigen, from nasal to nasal plus saliva.
That's incredibly exciting. You hear a lot of talk about antigen tests, and especially how rapid antigen tests could make a huge difference for us. And I think, these are the scientific breakthroughs that are really critical to helping us get the virus under control. So one question I have for you about the antigen test is a lot of folks in the US and in our scientific community have held the PCR test as the gold standard of testing.
Yes.
So where do you think the antigen test, fits in versus the PCR? And this breakthrough you're making, I mean, is it going to change the testing landscape in terms of where we still use the PCR?
I hope so. An N antigen test is a wonderful screening test. It is. It's a wonderful antigen screening test, and it's very good for verification. It's very good for screening, not necessarily used for verification, because it's not as specific as an S antigen test. But using the S, now you're extremely specific. It's a very definitive test. So now you have a correlation to a PCR.
Okay.
So an antigen, and no, it's a very good screening. And even with both the N and the S, in my opinion, it's only my opinion. I've only been doing this for a couple of days, but in my opinion, because this has been so devastating and such a shock to the economy, where states are closing, where shops are closing down, where people can't go out, they can't do this. And then they wonder about their employees. Can the employees come back? Are they sick? Are they not sick? So when screening is done on a massive scale, it's wonderful to screen for antigen. That's good. It's quick. It's easy. But when a person needs to come back to work, when do they come back to work? When the symptoms are gone right away? It's not the flu. This is not the flu. It doesn't quite act just like the flu. Someone goes away for the flu, they come back, well, I'm not sneezing, my fever broke, I can come back to work in 24 hours after my fever broke. This is a 10 to 12, 14-day virus. Some people have been sick for 3 or 4 weeks. Some people take 6 weeks to recover. So when is a person really able to come back to work? And the only way to scientifically know that is when their IgG is positive and there's no IgM left. The IgM is gone, but they're just IgG. Now, when the IgG is positive and there's no IgM, that means they have created the antibody that is fighting the virus, and they're most likely not, can't say 100%, there's nothing 100% in science, unfortunately. Most likely with a very high percentage that they're not contagious and they're not going to get the disease from someone else because their body's created the proper antibody to protect themselves.
Right.
So screening everyone with an antigen is wonderful. When they come back to work, they should be screened for an antibody test to find out if they have the IgG.
Right.
If they were positive and they're sending them home for 2 weeks and they automatically come back, that's a little loose because you don't know if that person, quote unquote, is the one that gets sick for 10 days or 14 or 3 weeks. And how susceptible are they to receive it again? Are they in the middle of it or are they contagious? To find that out, you have to do an antibody to find out what their IgG is. So that would be the best mix. According to Harvard Medical, on my little announcement we made the other day regarding tests, if an IgG and IgM come up positive, it's very highly likely the person has the virus. It takes longer to find out. It does. There are charts to talk about 1 week, 2 weeks, 3 weeks, 4 weeks.
Yeah, I can actually pull up one of those charts. I think it's really important to talk about.
This chart is days.
Right.
And there's another chart that's out that talks about weeks. And here's the funny thing. If you show symptoms and it's 3 weeks out from beginning of symptoms and you still have symptoms, that kind of symptoms that you're really sick, you have it really bad. And they would have been in the hospital after week 2. So weeks is too far. It's too long of a spectrum.
Right.
Because 1 or 2 or 3 weeks, 4, you see the curve and it goes 1, 2, 3, 4. If those are weeks and your IgM is up really high at week 3 or 4, there's a problem. Because that person is extremely sick and their IgG and IgM are both. The IgM has kicked in, yes. But They're still I'm sure their IgG still kicked in, but their still IgM is still very high. They're very sick, and especially week 3, and they're still 3 weeks of symptoms, which means they're sick. This disease is usually a 10 to 12 day cycle. So is 1 and 2 and 3 or 4 days? That's probably a little soft. You have one that's too far to the one end, and the 1 to 2, 3 days, because again, you have two different schools of science. You have one science group saying, "Oh, it's weeks out." Well, if that's true, then a week before you get sick, you can test for the disease according to the chart,
Right.
and up to a week after. And then at that point, you begin the IgM and the IgGs later on from date of symptom. That doesn't make sense scientifically.
Yeah.
Days makes more sense on screening on an antigen a day before, maybe 2 days before you can detect before symptoms begin. Yes. Then if you look at the chart, though, the PCR and the antigen test have the same start line.
Right.
And they peak about the same time.
Right. So the antigen is better for early screening, or it's
for sure.
Yeah.
It's just like a PCR in a sense. On the same charts, even if it doesn't matter what school of thought, if it's weeks or days, it doesn't matter. They both start about the same time.
Yeah.
So if it's a week early, the antigen test is a week early. The PCR takes a week early. If it's a day early or 2 days early, it's still a day or two. But the beginning time is exactly the same with the PCR as it is the antigen.
It's just the antigen drops off after two
because it's not the actual. On one, you're not. On one of them, you're looking. On one, you're looking for a protein on the virus, and one you're looking for a very specific gene of the virus. For a long time, we all know, and I'm thankful that the CDC was able to make mention of this, that a lot of their PCRs were false positives in the beginning. First, they're running too many cycles. They're running H gene and mainly H gene, if I'm not mistaken. When I looked at their charts, H gene is a very common gene. It's a very broad spectrum. And so if that whatever virus you had fit into that broad spectrum, it wasn't necessarily COVID-19. It may not even been a COVID. It may have been something else that had that gene in it. Therefore, the PCR is picking it up. So to become more accurate, you needed to really define your gene, and more define your gene, better your test. So when we worked with OneDrop, and we spoke with them, and because we have contacts in Wuhan, in China, where it all started, and so we had access to different things. And so working with and partnering with people, their PCR test doesn't use. It uses two different genes. It uses an RPRQE gene. And you say, well, why? Well, because the RPRQ is a specific gene to bats. It's very specific. So you want something that's going to be more specific to this specific COVID type of disease, not necessarily MERS, which is a Middle Eastern Respiratory Syndrome, which is a SARS type of test or disease of COVID, or SARS-1. Yes, are they similar? Yes, but I'm not testing for them. I want to test for COVID-19. And to do that, you want to be very specific to that gene to find out where it came from. And by finding out where it came from, I can test for it specifically. Now, we have modified, good news, I can mention it now. We have modified, and they have modified their testing, and we're down from 90 minutes to under 60 minutes. We do a 45-minute test, and you can run an entire panel of 100 tests.
Okay.
Now, the beauty about this is none of us are machine manufacturers.
Yep.
Even the 2 antigen tests that have been approved, Even though they say you don't need a machine, but both of them sell machines to go with it. I know one company that sells their machine. They sell it for $1,500, and you basically do the test, put on a cassette, put the cassette into the machine to read it.
Yeah.
Basically, the machine is a magnifier. So you're going to pay for the test, and then you can pay for the machine. We don't do that. We're not machine manufacturers. Some people really like machines. I was teasing with my staff and said, well, we can always buy machines that they can put the tests into and charge them an extra $1,500 just to make them feel better, that it's more scientific. They have a machine. But really, why go through the hassle when you can read the test and know exactly what the answer is, yes or no? Is there a line?
This PCR test that
right.
you're offering, which is a 45-minute test.
Right.
And you've worked with OneDrop to actually make it better.
And the accuracy is higher now. We recommend this. It's the cycles are different. We change cycles. Usually, it's a 2-cycle run. It's you have 6 to 8 cycles, which is runs, but you have different formulas of genes. So usually they're 2. We're running 4 now, which is new. So we run 4. You're actually being extremely specific. That's number one. So you're actually becoming more accurate. And if you run the same amount, you can come up with the answer quicker. So it's a tremendous breakthrough. And you can run a whole panel. Now, the beauty of it is we sell the tests, not machines. So what machine do we buy? Well, I know there's a lot of major manufacturers out there that sell machines. And
I think there's a compatibility list of machines, right, in the product details that you provide.
Yes, we give a whole list of different machines. So you're not buying our machine. We're not trying to sell a machine. We're trying to give you the tests. And it's a very interesting, but it's a new breakthrough, and I think we're very excited about that.
Yeah, and this has occurred to me recently. It's really not just one testing strategy that's going to win the day. I really see that there's a need for use of multiple testing strategies, and you really have to look at your situation and try to determine what's going to be the best approach, what's going to be the best way to address your testing needs. And just this whole conversation has been fascinating. We've been talking about the collaboration between various manufacturers and how the science is being shared, and also how there's opportunities to improve and develop things. And clearly your company is very focused on the R&D aspect, on bringing new, highly accurate tests to market. So, I mean, one question I'm always thinking is, what data do you use to know that a test is safe to bring to market, that it's has the accuracy that you're stating it has? And is there, how do you go through that process to once you've found the formula and you're confident that you have a test that's going to work?
That's a good question. There's a gentleman, his name is Michael, and he has been to our lab, and he has seen, I think we have 5 labs, 4 functional all the time, and 1 we use once in a while. But when you walk into our labs and you see 2 or 3 or 400 tests per lab table in several labs, we're running thousands of tests a day. Now you're thinking, does everyone run thousands of tests a day? I know a lot of large manufacturers that won't do that because of the cost, and there's a lot. Everyone wants credit for everything instead of coming up with the focus is let's make a great test. And so, is it that we just went, wow, look at this wonderful formula, we put it together and there it is? It's not. Is it trial and error? Yes. You come up with a formula and you try it, and you run not just 1 or 2 or 3 tests, you run hundreds and hundreds of tests. And you go, okay, now how can I modify this formula? And you modify it, and you modify it, and you modify it, and you modify it. And then you go, okay, I need to change either the antigen if I'm trying to make an antibody test. I need to change the antibody if I'm trying to make an antigen test. No matter what you're making, and that means not just for COVID, but for any type of test. So you're trying to refine what you're doing and your supply of the raw reagent to find out what am I doing, what is the formula. It's like cooking. If you're using old garlic that's 3 years old and you throw it in your soup, it may not have a good flavor to it. Is it the recipe? No, it's the bad garlic. So you have to start changing. So you go through hundreds and hundreds and hundreds of tests until you come up with a formula with the right ingredients that works. Now you may have run 3 or 4, 5, 6, 7,000 tests. I know we probably have run at least 7 or 8,000 antigen tests. And I mean, the day that Michael showed up, that day we probably had, between the 3 labs, we probably had 1,000, 1,500 tests on the tables. And that's not the only day that it was there. That happens a lot. So you continue to run your tests. Then when you define it, then you begin to run controls. How accurate is this?
Right.
How sensitive is this? And you run it by so many nanograms, and you start reducing the nanograms. Then when it becomes soft or weak or ghost line, and you know it's not sensitive enough, now you go back to the formula. Okay, let's redefine the formula. You start redefining the formula. You start making it more sensitive. I need to add this. I need to add that. I need to take this away. This. I need to reduce or increase the sensitivity or the strength of the buffer. Is the buffer overpowering? Is it in the colloidal gold? Is it in the exorbitant antigen or antibodies that we're using? Where is the lack of sensitivity that we're looking for? Until we get it to a very fine point, now can we reproduce this? So now you begin to reproduce the same formula, and then you retest to make sure that every time you do this, you're coming up with the sensitivity that you're looking for, or it would be sensitivity.
Just a scientific process, right? The iterative process of.
It just takes time.
Yeah.
And it takes time and effort and money and stick-to-itiveness. You can't get to go and go, oh, well, gosh, we tried, darn, we didn't do it. You can't do that. Your test
is 99.47% accurate, the antibody test.
Yes.
And that's the test that we call the Fat Boy, but I don't think that's an official
term. No, that's not the official name. No. It's because it's wider than the other tests. You know, he named it after me, really. No, I'm just kidding. But it's just, no, that's what we use. It's just because it's the POC test. So now we've changed the name to POC.
Right.
Which is point of care. Right. And so that one is really a good test. And we're changing the plastic on a couple of them. Not that one. That one's going to remain the same plastic for a while at least. And then the other ones are changing the plastic because a lot of people have gotten confused on. We haven't changed it yet. We're in the middle of it. Where it has buffer and sample.
Yeah.
They're mixed. They don't know which one's the sample, which one. You know, does the blood go here? So we're going to actually just put it all back into one spot. Add the blood, add the drops. We're done.
Yeah.
And that's going to with the EUA authorized one also. So all that's changing. I'll probably call it 3 weeks from now. We're working on we'll use the same plastic as I used before. And if we do, that's okay. But it's kind of funny. So we're just changing plastic. Yes, but the science on the inside is the same. But the absorbent pad, the wicking material, where the colloidal gold is, where the lines show up, all have to coordinate with the plastic.
Yeah. So
that takes a little bit of not engineering in the sense of design, but it's engineering in the sense of where do we spray? How do we not spray?
Yeah.
How do we increase? So that we're working on, we'll have done, but that's not a super duper priority. The antigen test is. So
Yeah.
that will be probably 3 weeks down the road.
Oh, that's super exciting. And I understand that a lot of these details that you're looking at actually have great benefits, like in the Fat Boy, where there's room, like if you make a mistake, you add too much buffer. There's control measures in place, basically, that allow for some level of user error. I mean,
100%.
it's never going to be 100% perfect.
No.
But I think that there's a lot of controls measures in place, including the control line,
Yes.
which basically tells you that it's a valid test that you've taken, that that the results are as stated they would be in the studies that you've submitted and provided.
Yeah, that's exactly right. The for us, we create. If you took it apart, you see that inside the plastic there is a little bridge that the test sits on, and the reason for that is in case someone forgets when they're counting to 2, they may count and go, you know what, I want those big enough drops. Let me add another drop. Instead of killing the test, it'll literally fall off the side.
Right.
Now, if they put 8 or 9 drops, like you said, it's not 100% foolproof. But on small errors, it's covered. We know that can happen. We've seen physicians do that. They'll go, well, those are 2 small drops. Let me add one more good one just to make sure. But it won't kill the test. It's not going to hurt the test, because that does happen. So you're right. We add little things inside, even in the design of the plastic, and that's on all of our tests that we do. Every one of them, all 100 plus tests that we do, that is something we do to all the tests.
So just have one last question on the antibody test, because I want to make it crystal clear for people out there that this test is testing IgM and IgG.
That's correct.
So can you just tell us a little bit about what you know about IgM and IgG? What are we expecting to see when we're testing those antibodies?
Sure. The IgM is a early detection. It's the first antibody that the body creates, is the IgM. And it starts off right away. It's basically the little red light that spins in the body saying, we have an invader. We need to do something about this. And it's when the body really can recognize the sickness. That's why it takes a few days for that to occur. Some viruses, the IgM starts right away, boom, and away she goes, because the virus is more active. It's more shown. It doesn't have any sleeper time. We've heard about this, the COVID having asymptomatic, which means it hides in the system. Not everyone's asymptomatic. Some people get it and they get sick right away. But if when the person's body really recognizes the virus, it's the little red light that goes off in the body saying, we have an invader. And the antibodies begin to build. Now, is that really the super killer antibody that fights off the virus? No. But it is the precursor to it, saying there's a problem. Let's begin to build up. And as it rises up, it literally ignites the IgM. The IgG. Now, the IgG is the fighter. So when a person has just IgM, means it's pretty early phase. Or they've been sick for a few days and they're saying, hey, now my body's finally recognizing this. I know some people that they were sick for 5 days, 6 days, and then it showed up. I know some people that they were sick for 3 days and it showed up.
What about asymptomatic people?
Excuse me?
What if you're asymptomatic? Could it show up?
It may not show up for 5, 6, 7 days. It will eventually show up. Because once your body recognizes it, if your body doesn't recognize it, then it's not going to show up. And it won't show up for a while, at least, until the body begins to recognize it. Even if you're asymptomatic, but the body has to recognize that the person's sick. And now once the IgM begins and it gets going, the IgM, the next trigger is the IgG. The IgG is the antibody that comes and does all the fighting. It's the fighters. So when the body has just IgM, it's the beginning. When it's IgM, IgG, they're right about in the middle. They're right in the middle of the fight. When it's just IgG, which means that the body has now really conquered the virus, and they are on the other side of this. In most cases, that means they're no longer contagious, and the body will create this antigen for a while. How long? Again, depends on the person.
Right.
You know, studies showing 30 days, you know, people showing 90 days.
Right.
So we don't call that.
And so this is really fascinating. And this chart is a chart of antigen, antibody, IgM, and IgG, and when it could appear. And what I've found is that there's many different charts out there, and it doesn't seem to me that the science is like 100% solid on this. But what I've learned, because Charles, I mean, we've been doing the testing for people, and we're learning more and more as we do more testing. And I think that that's really the important part. Is we're not gonna know. It's not a hard and fast rule for every individual.
That's exactly right.
When these antibodies will show up, when the antigen will show up. But that's why you have to test frequently and regularly.
That's exactly right. You're exactly right. This is one part about this virus. It's unique in a sense. Dr. Tree said it best. He said this is a very unique virus in the sense that it has so many mutations, and that's one thing. But for a while, it wasn't fully mutating, but it was mutating in a sense of detectability. He calls it the mass. This virus would have different mass, so it became very difficult to pinpoint it. That's why the vaccine's taken so long, because you have to be very specific in what you're looking for. So even for testing, some people react one way, some people react another way on this one specific virus. And flu, the symptoms are pretty standard. Now, some people get it more severe than others, but they're pretty standard. You don't feel well for 2 to 5, 6 days. You have fevers. You know, you have your little list of things that the standard flu has.
Right.
Severe flus are different. This virus, the spectrum of the symptoms are vast, and because they're so vast, people's symptoms can be very mild or extremely fatally severe.
And it's the different strains of the virus.
But it's also the way each person's body is reacting to it. That's why it's difficult for testing on the antibodies and IgG or IgM or even antigen or even PCR. PCR is not infallible. It's been proven to have made false positives and false negatives. But people say, well, how can you do that when you're doing a DNA, chain reactive study? Well, because you're not really doing you're doing a genetic study on a specific part of the gene, which if it changes its face, you're looking for something wrong. So now you end up with a false negative. Yeah. Or if it changes its face, now you end up false positive because you went this way and it went that way. And it's a very unique little virus. And I think I would say it's designed that way, but however it came out, it is for sure an interesting one, which will keep all of us in the industry, as we now know. We thought it was over with, and we just had the third wave, and the third wave is fairly severe. And so will there be another wave? Well, probably if this one doesn't die out quick, then we'll probably have a solid, good another wave probably in February or March of next year.
Yeah, I mean, cases are going up. It's very scary. It's hard to see, but I mean, this is exactly what everyone's been talking about, and it's very clear that we need more testing and we need more data. The data is a critical part of this to be able to understand how people can get exposed, to understand who's been exposed, how that might have happened, We have to, continue to improve the safety measures we're taking. When people do have to inevitably interact with each other, and there's a lot of people who don't have a choice. They have to go out. They're essential workers.
That's right.
They're frontline workers, and they are putting themselves out there to exposure. So I think that the cases are going up and exposure is happening, and we have to understand how it's happening. It's a really, really important thing. So your antibody test is testing for SARS-CoV-2. Is there what possibility is it that it could detect IgM for any other virus? I mean, is that highly likely or unlikely?
How highly likely is it possible? Yes. You have to run cross-reaction tests. So you run a whole panel of the standard tests, flu and strep and a whole group. And then the FDA, of course, requires everyone to run a cross-reaction to other COVIDs. And you have to try to set your test where it really doesn't pick up as a cross-reaction positive to other COVIDs or coronaviruses. But is it possible? The answer is yes, a solid yes. Is it likely? No. The word possibility in this, especially with this virus, is very unique. So the answer is yes. It is possible, but highly unlikely.
Yeah, and that's what I want to caution people is that when you get a result, talk to your doctor. Don't try to, figure it all out on your own, or even, you may need to reach out to us at ConquerCovid so we can tell you what to do, because it's crazy right now about the different scenarios that can happen, the different positive tests you can get, negative tests you can get, and I don't think that people need to go jump to any conclusions. But our recommendation 100% is that you get a broader range of tests and you confirm your positive tests with a PCR test. You want to know whether it's an active virus. So even if you do get that positive IgM, you still want to confirm it with the PCR test and make sure that's positive as well, because there are different medical reasons why you could get different results, and you have to be aware of that. It's important.
You're absolutely right. This type of test that you want to confirm. And there are some tests that we put out there that we actually say that, if you feel that maybe it's not exactly right, get tested again, test yourself again, and when you do, then you at least have peace of mind. It gives you some peace of mind. And then, but if this is a type of test that sometimes it's not necessarily the first test round, you should test yourself and then retest yourself again. If it's not the same day, retest yourself in a few days, a week, but make sure you retest yourself just to make sure that you're on the right path and that you didn't test yourself too early. And then a few days later, it begins to show in the testing that the person is positive, because you do want to catch all the positives we can so we can get a grip on this virus.
Absolutely. Yeah. It's so clear what testing could do for us, how it could help us make better decisions about limiting our exposure when needed. So you've talked about this antigen test that's coming out, which is also very exciting because when you talk about a testing solution, you're going to want a combination of the antibody testing, the antigen testing, and in some instances, the PCR test. What I've seen out there is we're heavily relying on the PCR test, which is the most expensive test of all the tests.
Yes.
Because of the additional lab equipment, lab work required, the logistics of transporting the sample specimens to the labs. And so we've seen a lot of towns, cities, organizations start to roll out these testing measures. But I think that there's a huge opportunity here to increase the frequency of testing by getting our costs down and using some of these screening tests, like the rapid antigen test that you're coming out with, which I think is going to be a game changer, a point of care test that's highly accurate, tests the S and N antigens, and is a very effective screening process. Because am I correct in saying that if you get a positive on that test, it's
positive.
It's positive, right? I mean, it's
highly, it'll be not much different than getting a positive from PCR.
Yeah, so that's, I mean, and that you get that result in 15 minutes.
That's right.
So that's, for airlines, for any organization that is doing this screening to make sure that they're limiting the exposure for the people that are in their community. This could be.
That's huge.
This is a really big deal.
That's exactly. This is an opportunity to get a handle on this virus.
But at the same time, I'm in the camp where if you look at South Africa and you look at the UK, they're doing serological studies. They're testing populations of people for antibodies. And I don't see there to be any reason why a group or organization wouldn't move forward with that as well. Because, again, it really is about understanding, who in your community may have been exposed, how that could have happened, getting a grasp of who in your community has had COVID already. And when you can start understanding the people in your group more, then you can, really get to fine tune that testing strategy and understand how do we treat these different people and get to the safest environment. Because I think in the end, we want to limit spread, right? And that's something that I've been thinking about a lot. We're not going to stop this thing. It's not going to be like you flip a switch and everything goes to zero, because
it's going to be different now.
We're just trying to limit the damage, limit the impact, save lives, save that person from exposing someone else because they didn't know that they had the virus. They may have been asymptomatic.
That's right.
And that's what is a lot of people's concern, is about asymptomatic spread.
That's exactly right. And this is going to be around like your flu. This is going to be something that's going to become a standard testing from now on. And so you mean just antigen testing? Antigen testing is going to be probably the lead on it, especially once the vaccine comes out. But it should not be the only testing. The antibody test has its own value, again, because it is different than the flu. Once a person's tested, when do they come back to work? When are they back in? When they're testing positive for the IgG antibody.
Right.
Because we want to make sure that they're on the other side of this and it's not lingering within them.
Would a negative antigen test tell you that they weren't infectious?
It would say that they're not infectious. That's the funny thing. When we looked at the chart, and go back to the chart, you'll see how it scopes up and down within a day or within a week. So are they still contagious past that date? They sure are. When you begin to look at when the IgG and the IgM are, there's the point of detectability is past that time. So in other words, you can still detect it past those dates or times, which basically means it may come up negative, but they've gotten past it, but they're not past it yet. So yes, but they're not fully into the IgG, where just the IgG is all by itself and alone.
Yeah, infection is a can of worms, right?
You don't want to risk it. A PCR machine should pick it up, even according to the chart. The PCR machine should still pick it up. An antigen test won't. A rapid antigen test won't. But a PCR machine will pick it up.
Right. So that's the scenario. I mean, we're using these rapid tests to screen.
Right.
We're covering a lot of the population with it. And then when we have a question, we go to the PCR
That's
And
exactly right.
you're offering all of those tests, and
Exactly.
you're manufacturing them in San Diego, which is an American-made product. You've talked in detail about the reliability of your tests, which really is the science that goes into it and the formula that you're using. And all of your tests, well, you're still pending FDA emergency authorization for the antigen test, but your PCR test and your antibody test are FDA emergency use authorized.
Yes, sir.
So any medical provider, any medical professional can purchase these tests, and they can they'll be manufactured in San Diego, and they'll get a quality, reliable test that can help for them to protect the people in their community and their organizations, and also try to get a little bit of control over this virus. Because, I mean, what do you think is going to happen in 2021? That's the big question that everyone's asking. You know, the vaccine is coming out. I have my own opinions about the rollout and about what the logistics of everything can be. But, I mean, let's just address this. Does that mean we don't need testing? I don't believe so, but...
No, I believe testing is going to be around for years.
Yeah.
And the testing is going to be, I mean, there's vaccines for the flu. Did we stop testing for the flu? No. There's vaccines for pneumonia. We still test for it. There's vaccines for a lot of things, but we still test because people still get sick. This disease, unfortunately, this virus, it has set root. It's not something that came and went. This virus has set root, which means it will be around for a while, even after vaccines. It's not.
That's why we need a process in place, right? I mean,
exactly right.
What some states have done, if you travel from some regions of the country to another region of the country, you're required to show a negative test certificate, which shows that you've been tested, that you've got a negative result, or you are required to quarantine for 14 days.
Right.
I think there's going to be some processes in place when people start to come back to work, when children are going to school, that there's a process in place to show that you've gotten a negative test and you're safe to participate in that environment. But at the same point, we're not saying don't mask. We're not saying
exactly
don't do hand hygiene. You have to do all those things. You have to socially distance. You have to wear your mask. You have to do hand hygiene, and you have to show that you're getting those negative tests. And that's going to create the safest environment to stop the spread of the virus.
You're absolutely right. We have to do all the above. Literally all the above, and test.
Yeah, so December is a really big month, and hopefully, you know, we're coming on Thanksgiving this week, and happy Thanksgiving to you and your family. It's I think a very different Thanksgiving time, but we're all being safe, and we're all, you know, taking the measures that we have to, because you see cases are going up. And then we have Christmas coming up in December, and then the vaccine is coming out. So I think it's a very uncertain environment to me. If I were someone who's really trying to mitigate their risk in the future and protect themselves, I think you would want to start creating these testing programs, get them up off the ground quickly, and you have manufacturing capacity.
We do.
For
1,000 a day right now.
To know that, you know, Charles in San Diego has manufacturing capacity to get these tests out, and it's really something that people are already doing, and there's a cost to not doing it, and that's what I think everyone needs to understand is you're going to have a comfort level once you start testing regularly. And just like every professional sports organization has done, just like the White House was doing, there are many groups of people who recognize that testing is the only way to limit exposure. It's the only way to catch early potential infectious people and get them out of circulation, right? Just You got to
That's right.
keep those people and get them out of circulation so that they're not spreading the virus to anyone else.
Absolutely right.
Well, that's I mean, it's a lot of information. We talked for a while. I think we should definitely keep in touch and do this often, and you know, stay up to date on the science. And
we'll keep you abreast.
Yeah. So anything else? Any last comments?
As you stated, test often, wear your mask, wear your gloves, do your social distancing, keep safe, and if you think you're sick, go and get tested or test yourself.
Well, I appreciate it, Charles. God bless you, and
God bless you too.
Work that you and Dr. Sue are doing. And I'm sorry, I will get his name right next time.
Dr. Tree.
Dr. Tree. And I've seen that he's working very, very hard. And please give him my regards. And we're very anxious and looking forward to your pending FDA approval. So
thank you very much.
Thank you.
Thank you so much.
Take care. Have a great Thanksgiving with your family.
Thank you. Bye-bye.